are worth more than are worth.
Good afternoon, and thank you very much for coming. Sorry we're starting a little bit late. We're trying to get some technology working. My name is Stephanie. I'm one of the co-chairs of the Heart Society, and we have a talk on heart sounds from OSCE for you guys tonight. So our speaker is Dr. Randeepa Hidirachi, who is a MRCGP qualified GP who works in the Imperial Trust. He has taught Imperial third-year students for several years now, and is very well loved by students for his enthusiastic and interactive manner of teaching. He gave this heart sounds talk last year, which was very well reviewed, and he has also spoken at a cardiology conference. He is also an OSCE examiner who will now take you through the heart sounds process.
Okay, can everybody hear me all right, first of all? Even at the back? I remember when I used to be a student here, I used to sit at the back, hide away, but as long as everybody can hear me. If you want to come closer, it's not a problem. It's not that scary, okay? Right, heart sounds. So can I just get a show of hands, how many of you are year 3 students? Oh, pretty much everybody. Any other years? Year 4? No, 5? Final years? So mostly year 3. So you guys have got your OSCEs coming up in a few months? Few weeks? Is it a few weeks or? Wow, okay. All prepared? Ready? All prepared for year reviews and stuff like that? Okay. Anybody interested in cardiology? Anybody cardiologists? So as Steph was saying, I trained at Imperial and I'm a GP. I work in Buckinghamshire now. And I've done my postgraduate exams, MRCP, MRCGP, and I've got an interest in cardiology, so I do a lot of cardiology as a GP. All my colleagues kind of send me all the interesting cases, so let's try and work you through some heart sounds, heart murmurs, and get through these OSCEs. Right, so let's see, technology was having a bit of trouble with that here. Okay, so basic anatomy of the heart, I'm sure all of you guys know. The heart's made up of 4 chambers. You've got the left atrium, you've got the left ventricle, you've got the right atrium and the right ventricle, and you've got valves in between all of those chambers, and also obviously the entrance and the exit points. We don't need to go through too much about that, it's a bit boring. And then the areas. So when we obviously do a cardiovascular examination, and when we auscultate, there's a little bit of anatomy which we should be a bit aware of. When we refer to the mid-sternal line, we're effectively referring to this particular area. And when we refer to the mid-clavicular line, effectively we're referring essentially down this area, obviously on each side. And the anterior integumentary line, we're effectively referring to this position here in the person. So if I was to ask you guys to tell me where the aortic area is, where would you use that stone? Don't shout at once. Anybody? Should have shouted a bit louder, sorry. Fantastic. And what about the pulmonary area? Who's speaking? So much to see. Sorry. Yeah, okay, great. Okay, and should we finish off with the mitral area? 4 intercostal space to the. I think it's usually referred to the mitral area as the apex. Yeah, which is the 5th intercostal space, mid-clavicular line. Yeah, it's fantastic. And finally, the tricuspid area is what we were referring to, which is the left sternal border. So right, okay. So that's effectively that's what we were talking about. So pulmonary area is the left second intercostal space. The aortic area is the right second intercostal space. Tricuspid area is just at the left sternal edge. Does anybody know there's another name given to this particular area? Anybody know that? Yeah, fantastic. Well done. That is indeed called Erb's point. And finally, the mitral area, which is the 5th intercostal space, the intercostal line. That's effectively where the apex meets. So in the OSCEs, don't put your stethoscope down randomly. Make sure you put it down in all these 4 areas, because that's effectively a mark for you guys. And we need to see you do that very well in each of those areas. Just show the examiner that you're doing that in those particular areas. Right. Hard sounds. I think everybody knows the first hard sound is effectively when the atrioventricular valve is closed, so that's the mitral valve and the tricuspid valve. And the second hard sound is when the aortic and the pulmonic valve close. So, I'm just going to go backwards. Normal hard sounds. Got the first hard sound, second hard sound. It's very, very common that when we breathe in, the second hard sound can split. So effectively what's happening is the aortic valve is closing just before the pulmonary valve. Very, very common. It's physiological. Don't really panic about that, especially in young, fit athletes, tall, thin people. Quite common, we don't really worry about that in inspiration. And third and fourth hard sounds. Anybody tell me a little bit about the third hard sound? Abnormal, normal, okay to have a third hard sound? Yeah, good. Third can be normal. Can you tell me some examples where it could be normal? Yeah, in any conditions that it could be normal. It can be a normal phenomenon in a normal person, but there are other kind of conditions which we don't tend to panic about when we get third hard sound. Anything anybody know? Okay. Alright, we'll talk about it. So basically, just a little bit about third hard sounds. Well, both third and fourth are low in frequency, and it's really best with the bell of the stethoscope. Usually best head over the apex with the patient in the left lateral position. So if you ever want to hear a third and fourth hard sound very clearly, do that. So third hard sound we're talking about, it's basically results from increased atrial pressure, leading to increased flow rates. For example, it's probably seen, well, most likely seen in heart failure, that's the most common cause of a third heart sound. And it can be normal, as we were saying, in somebody under the age of 40, or in people who are athletes, or ladies who are pregnant. You get a third heart sound, absolutely fine to have that. And also, in other conditions where it could be as a result of mitral regurgitation, you can get a third heart sound. Locum, very common to get a third heart sound. And people who are anemic, and obviously hyperthyroidism, another 2 common causes of the third heart sound. So just be a bit wary of that in terms of the third heart sound. Fourth heart sound is abnormal or normal? Anybody? Abnormal, yeah. The way I kind of asked the question probably is. So the fourth heart sound is abnormal, and it's basically seen in patients with people who've got the left ventricle which is very, very stiff. So, for example, in patients who've got hypertension, aortic stenosis, and cardiomyopathy, whether it's hypertrophic or ischemic. It's basically associated with left ventricular hypertrophy in those conditions which we just mentioned, and also it can be due to right ventricular hypertrophy, seen in pulmonary stenosis. So third heart sound, all right to have under the age of 40. It's a physiological finding in pregnant ladies, for example. Fourth heart sound, basically as a result of conditions which are listed on there. Okay, manners. This is why everybody's here. I think everybody wants to learn a little bit about. Manners are basically extra heart sounds that are produced as a result of turbulent blood flow. And that's why we hear the noise. And it's basically because, as you all know, it's either a leaking valve or a valve which is basically narrowed. When we talk about manners, we need to basically mention, especially in the exam, whether it's a systolic murmur, or whether it's a diastolic murmur, or whether it's indeed a continuous murmur. So what we mean by systolic murmur is effectively happening between the first and second heart sound. And obviously a diastolic murmur is when the heart relaxes, so it's effectively happening after the second heart sound, just before the first heart sound. And of course, when we describe a murmur, we need to tell the examiner where it is. So that's why we go into obviously the 4 areas. And it's important to kind of tell us whether it's a systolic, a diastolic murmur, and where exactly you hear it aloud. Whether it's the apex, whether it's the aortic area, artery area, or the tricuspid area. Those are the 4 key areas that you need to obviously try and work out where it's allowed. And of course, as you get more experience, you can try and grade the murmur. Grade 1 effectively is when the murmur is pretty silent or faint, and grade 6 is, well, that is really, really loud. Most of the time you can probably hear it from the end of the bed. But grading is obviously very difficult, and it's usually done by obviously experienced cardiologists at your stage, especially the 30 years. Don't really need to grade the murmur. The key thing is systolic, diastolic, or whether it's where exactly it's let out. So effectively, that's the key thing that you guys need to mention: systolic and position where it's let out. We'll talk about other key things as we go along in the lecture. Right, murmurs, they can vary with respiration, and particularly the right side of murmurs. The valves are on the right side of the heart, so the tricuspid, and stuff like that, can vary more than the left side of murmurs. Anybody know which murmurs, for example, does the right side of murmurs increase with inspiration or expiration? Sorry? Inspiration, fantastic. And obviously the left side of murmurs increase with expiration. Okay? And of course it varies with the position of the patient as well. For example, the mitral stenosis murmur is at best with the patient in the left lateral position. The aortic regurgitation murmur is at best when the patient is in forward. So little mnemonic, I'm sure you guys all know: left E for expiration, right I for inspiration. Okay? Right, now, we talked about murmurs, where they are, systole, diastole. As I said, it's very important to let us know where exactly it is. Now, just a point to mention, innocent murmurs are always systolic. Okay, you never get a diastolic innocent murmur. Probably very rare. You never really get a diastolic innocent murmur. So, innocent murmurs, whether it's basically because of, for example, a flow murmur or something like that, it is always a systolic murmur, and it usually doesn't radiate. Best heard just at the left sternum border. It's usually a bit systolic murmur. When we talk about systolic murmurs, there can be injection. Basically, implying there's an obstruction or a high cardiac output. Common injection systolic murmurs are aortic stenosis, so I'm sure you're all aware of. Occam is another common one, and obviously pulmonary stenosis. You can also get injection systolic murmurs in patients who have, as I said, a high cardiac output, which you see in anemic patients, in patients who've got thyrotoxicosis, and they will have got ASDs and VSDs. So those are the kind of injection murmurs. Then we've got pansystolic murmurs, which effectively what they're saying is that the blood is flowing from a high to a low pressure chamber. So common ones are mitral regurgitation, blood is going from the left ventricle, which is a high pressure area, to the left atrium, which is kind of a low pressure area. Similarly, tricuspid regurgitation happening on the other side of the heart. And VSDs going from the left ventricle to the right ventricle. So those are the common pansystolic murmurs. So, diastolic murmurs, pretty much always normal. Something gone wrong with the valve, effectively. And common ones are aortic regurgitation and pulmonary regurgitation. Of course, mitral stenosis. Right, so if I ask you to summarize and tell me now you should remember what I've just mentioned. So if I ask some of you guys to tell me some injection systolic murmurs, run through them very quickly. Aortic stenosis, the commonest one. Any more? Fantastic. So just remember those two. Nice and easy now. Tell me some pansystolic murmurs. Yes, okay, yeah. More common than that? mitral regurg. Another one? Tricuspid regurg. I think those are the key things that you need to remember. Mitral regurg, tricuspid regurg for a pansystolic murmur. Okay? Name me one diastolic murmur. Aortic regurgitation, which you should know for the exams. Fantastic. And that's how they figure that. Okay? So, common ones. For systolic murmurs, aortic stenosis, pulmonary stenosis, mitral regurg, tricuspid regurg. Okay? Those are probably the common ones you guys. Don't worry about actually pulmonary stenosis, probably aortic stenosis, mitral, tricuspid. Common diastolic, aortic regurgitation is probably the one, and mitral stenosis is the important one. So those are the key ones, and effectively, that brings us on to the 6 must-know murmurs really for your exam, and whether it's OSCEs or whether it's the EMQs. The reason is, aortic stenosis, easy to find, elderly lady, bring them into the OSCE, and you guys should be able to pick up that murmur. Okay? Occam probably won't bring a Occam in, but it could be an EMP question, and we'll talk about obviously the presentation of Occam. Mitral regurgitation, you can find one of my colleagues at work at mitral regurgitation. So yeah, they're pretty stable. You can bring them in, and it's an easy murmur for you guys to listen and pick up. So what I'm going to say is in the OSCE, you're more likely to get a systolic murmur to listen to. But never say never, you could get a diastolic murmur. But I think you're more likely to get aortic stenosis, mitral regurg. Tricuspid regurg, well, if you're unlucky, don't have a feeling today. I think it's more close to that, but you should know the basics from this. Okay? Right. Going to get very interactive now, guys. I think you're all falling asleep. So, case study. 50-year-old male with a known heart murmur presents with complaints of substernal chest pain, which increases with exertion, and shortness of breath, which is starting to mimic his lifestyle. So no risk factors for coronary artery disease. Your budding cardiologist, you've done an examination, you find that there's a delayed carotid artery stroke, a good going apical pulse, and prominent A waves in the neck. Oh my God, you must be a very good cardiologist to pick that up. What murmur am I trying to describe? You got it? Aortic stenosis? Yeah? Can you tell me some reasons? Yeah? Anything? Sorry?
That's why.
That's why, okay, fantastic. Anything in the history that could kind of give the game away? Anything in the history? So if you got this in the EMQ, without the examination part? Yeah. Okay, yeah. Okay, so there's no harm. Not bad. Okay. Yeah, you're right, aortic stenosis is the right answer. Really, in the history, aortic stenosis has the classic triad of symptoms. You've got your chest pain, you've got your shortness of breath, and you've got one other thing which is not on the history, it's the syncope. The 3 things in terms of aortic stenosis, the classic triad: shortness of breath, chest pain or chest discomfort, and syncope. And of course, in the examination, you've got the delayed carotid artery stroke because of aortic stenosis. So, what's that ECG trying to show? Why are they on there? What's the link with aortic stenosis? Sorry, I can't say that again. Yeah, left ventricular hypertrophy. Very good. How did you work that out? Yeah. Did you count the squares? Yeah. Well, there is a rule, isn't there? If you count the downward stroke and the upward stroke, and if it equals closer to 7, large squares, it's probably LVH. So left ventricular hypertrophy is associated with aortic stenosis. Okay, so the left ventricle basically enlarges because of aortic stenosis.
Which squares do you count?
Sorry?
Which squares do you count?
So you count basically these large squares. 1, 2. So it's basically downward stroke on B2 leads. 1, 2, 3, 4, and usually V6, 5, 6. And they usually equal about 6 to 7 squares, so just size above the edge. Right, aortic stenosis. We all know that murmur, I'm sure, which is ejection systolic murmur, loudest in the aortic area, which is the right second intercostal space, as we were talking about, and the aortic stenosis murmur radiates to the carotids on pretty much most occasions. What's the causes of aortic stenosis? Everybody likes to say rheumatic fever for any murmur. Yeah, I'll give you that. Rheumatic fever is probably one of them. Yeah, anything else? Calcification is a very common cause for aortic stenosis. And of course, it can be congenital as well. And then we talked about the clinical features, which is basically you get a slow rising pulse. You get a narrow pulse pressure. So what we mean by that is when you do your blood pressure, the systolic and the diastolic are very close together. So it's something like 120 over 90 or something like that. The apex, because of the hypertrophy, is very forceful. And the classic triad of symptoms which I talked about, which is the shortness of breath, chest pain, and syncope. And of course, we can do an ECG, and it will probably show a bit about the age as well, in aortic stenosis. So, something that you should be able to differentiate is aortic stenosis from aortic valve sclerosis, which can happen in the elderly. It's basically age-related degeneration of the heart. Most of the time they're asymptomatic, the aortic sclerosis, and they don't have the classic symptoms. And it doesn't really radiate to the carotids. That's good giveaway on examination, because you probably get the same murmur, ejection systolic murmur, in the aortic area, but in most cases with aortic sclerosis, they're asymptomatic and it doesn't radiate. Whereas in aortic stenosis, it can be asymptomatic, but in the murmur, in most cases, it does radiate. And the classic symptoms which we spoke about. Okay. Any questions on aortic stenosis? Happy? Okay. Our next case study. You've got a 45-year-old male with a history of rheumatic fever, presents with progressive shortness of breath on exertion, and is progressively getting worse. He has also developed intermittent complaints of palpitations. You do an examination, you notice that he's got a raised JVP, high respiratory rate, with some crackles on the lung exam. What's the case telling you? Mitral stenosis, why?
It's commonly associated with rheumatic fever.
Sorry, who's talking? Sorry, yeah, Karen.
Associated with rheumatic fever.
Yeah.
Also would cause backflow into the lungs, cause crackles.
Yeah, so it's basically rheumatic fever is usually a common cause of mitral stenosis. So if you ever mention rheumatic fever for a cause, big mitral stenosis over any of the other murmurs. And you're absolutely right, they're basically showing a little bit of fluid in the lungs as a result of mitral stenosis. So they're presenting with a bit of pulmonary edema here. This is why they've got a bit of raised JVP and crackles on the lungs. So mitral stenosis, what's the murmur in mitral stenosis? And the apex in what position? Left lateral position. So in your OSCEs, as part of your cardiovascular examination, when you listen with the valve of the stethoscope in the apex area, please rotate the patient to the left lateral position and prove that you're listening out for that murmur. Okay, another little hint. Does the mitral stenosis murmur radiate? Good. So that's mitral stenosis. It's a rhombolytic diastolic murmur at the apex. Left lateral position is where it's at loudest. Okay, so etiology we talked about, probably most common is rheumatic fever. And the clinical features are, as we mentioned, is usually signs of heart failure. So shortness of breath, paroxysmal nocturnal dyspnea, orthopnea, so when you lie down at night, you get breathless. Maybe hemoptysis because of the pulmonary edema, not because of the lung pathology. Most commonly associated with atrial fibrillation is mitral stenosis. And on a chest X-ray, because of the backflow, because of the not the backflow, sorry, because of the stiffened valve, left atrial fluid is a little bit larger than normal. But the key ones are really these kind of symptoms. and AF. So if you see an EMQ, AF, and murmur, it's mitral stenosis. Important points, as I mentioned, rheumatic fever, malar flush, again it's like flushing of the cheeks. What do we mean by tapping in neck speed? Anybody know?
You can palpate first concept.
Yeah. It's pretty fantastic. Spot on. And so you can actually palpate the first heart sound. And the heart sound is very loud. Why is it very loud? In mitral stenosis. We all know that the first heart sound is caused by closure of the mitral valve. It's one of the valves that closes for the first heart sound. So why is it very loud? Think of it logically. Yeah, well, because it's a stenosis, the mitral valve is effectively thickened. So it creates a massive sound as the first heart sound. And what do we mean by opening snap? So if you see that in EMQ, it gives away that it is mitral stenosis, but what do we mean by an opening snap? What's caused it? So the mitral valve is already thick, and it has to open up. So it's the opening of the mitral valve veins diastole. When the heart relaxes is what causes the opening snap. Okay, so just to differentiate between the two. So you get a loud first heart sound, and you get an opening snap. Commonly in mitral stenosis. Okay. Another case study. We have a 52-year-old female who presents with complaints of slowly progressive dyspnea on exertion and uncomfortable awareness of pulsation in the neck and chest. You do an exam and you find all of these abnormalities: brisk pulses, wide pulse pressures, quick ease pulse, head bobbing, pistol shot sounds. What am I trying to describe? Aortic regurgitation. And tell me your reasons. Okay. Yeah. And the wide pulse. Do you know what the name given to head bobbing is? Sorry? Do I need to give the game away? We'll talk about it in a second, alright. What about, what do you mean by quick ease pulse? Is it?
When you press, you can see the base that goes up and down.
Yeah, you're right. Okay. And the what about what do you mean by pistol shot sounds? Yeah. It's very loud. You hear like a massive bang in the femoral pulse. So yeah. So those are aortic regurgitation. What's the murmur? Anybody know the murmur? Sorry? Okay, whereabouts? Where is it left-handed?
Or no, yeah. Left. Left.
Oh, that's so many different things, sorry. It's a very nice solid number, yeah. Left-handed.
So on the left side, second.
Quite the left second intercostal space. Yeah.
Fourth.
Left sternal border, okay, so it's just lower down. And in what position? And in? Expiration. So, as part of your OSCE cardiovascular examination, you tell the patient to sit up. You bring your stethoscope down to the left sternal border, you tell them to take a deep breath in, you tell them to breathe out, and you tell them to hold their breath. Because that's effectively you listening for an aortic regurgitation in the left sternal border. Okay, because you're trying to listen out for a early diastolic murmur at the left sternal edge with the patient sitting forward and after expiration. Okay, so that's part of the maneuver that you should do as part of your OSCE cardiovascular examination. Causes for aortic regurgitation? Don't say rheumatic fever, that's already done. Any other causes? Yeah, I think an cardiac can really affect any valve, commonly the mitral valve. Yeah, not a bad guess. But yeah, the more common, one of the commonest causes for aortic regurg. What's a common acute cause for aortic regurgitation?
Dissection?
Yeah, aortic dissection. Okay, you rip the aorta, the valve also leaks. Okay, acute cause. Chronic causes? No, sorry. A more common chronic cause for aortic regurg.
Having Marfan?
Yeah, who said that, sorry? Marfan's, yeah. So connective tissue disorders is a common cause at Marfan. So connective tissue disorders like ankylosing spondylitis and Marfan's is another common cause of aortic regurg, more chronic aortic regurg. Acute being basically a dissection. And of course, the venous rheumatic fever. Okay. Clinical features for aortic regurgitation? Okay. Collapsing pulse. Anything else? You're telling me signs now. I'm talking about symptoms. How do they present? How are they going to tell you what would kind of give the game away before you examine them? Anything, if at all? Probably have a bit of palpitations, a bit of angina. Okay. But in most cases, they can have no symptoms and signs of left ventricular failure. And in terms of the signs, you have collapsing pulse, wide pulse pressure, and because of the volume overload, because of the leaking valve, the apex can be displaced as another common cause. Anybody know what a Austin Flint murmur is?
Pseudo-lumbar MS?
That's you, David, yeah. Yeah, so, yeah, basically, yeah, absolutely spot on. So, it's the diastolic lumbar mitral stenosis caused by the aortic valve, which is basically the regurgitant jet is hitting the mitral valve and causing the diastolic lumbar, which is similar to mitral stenosis. Good. So, the trope side is the pistol shock femoris, which we were talking about. Which is further over the femorals with each heartbeat. And we talked about all of these famous signs. So the carotid pulsations is called Corrigan's sign. Quincke's sign is the nail bed pulsations. And the head bobbing is the Denosset sign. Okay? So those are the key things. You're probably never going to pick these up on clinical examinations, more kind of for your EAQs. If they mention any of these things, it's kind of given to get away. That's most likely aortic regurgitation. The key ones being the ones at the bottom. Corrigan's, Quincke's, and the Denosset sign. Okay? We talked about this. Aortic regurgitation can be acute or chronic. Acute being basically because of an aortic dissection, and chronic being because of connective tissue disorders, and of course the congenital bypass of the aortic valve, which is what you guys mentioned. Okay. Finally, we've got a 75-year-old male who presents to A&E with severe chest pain. He's acutely short of breath. He's got paroxysmal nocturnal dyspnea, and he's got apnea. He's hypertensive, he's tachycardic, he's in respiratory distress. He's basically really unstable. He's got crackles all over the chest. And what are your thoughts? What's happening to this person? You dead?
Add an MI that causes mitral regurg.
Okay. So yeah, it's probably having an MI. What's else? Yeah, it's probably having mitral regurg. What else is happening to it? Pulmonary edema. Yeah, absolutely. So yeah, it's probably having an MI, which is basically cause pulmonary edema, and it's probably having an effect on its mitral valve. Is your ECG? What's wrong with ECG? And you'll stand here until somebody tells me the answer. ST elevation in 2, 3, and AEF. So, what's your diagnosis? So, Kristen, inferior MI. Anything else on the ECG?
Active depression, you want me to
So, what's happening there?
posterior?
Well done. Posterior MI. So, it's got an inferior MI because it's the inferior lead to 2, 3, and ADF. And it's got ST depression in the anterior leads. Turn the ECG upside down. That ST depression looks like ST elevation. So it's having an MI at the bottom of the heart as well as the back of the heart. So inferior and posterior MI. So if you ever see ST depression in all the leads, think posterior. But it's obviously having a posterior tends to kind of go with the bottom of the heart as well. Tend to go hand in hand most of the time. So yes, having the inferior posterior wall myocardial infarction. So you're right. Brings us on to mitral regurgitation. Oops. What's the murmur in MR? Yeah, and loudest. Radiating to the axilla. Fantastic. Pansystolic murmur. And loudest at the apex. Radiating to the axilla. Causes for mitral regurg? Yeah, we have to deal with that. Anything else? Common causes? Yeah, MI or ischemic heart disease, yeah. Anything else? What condition can commonly affect, apart from mental fever, affect the mitral valve? Infective endocarditis. Good, so ischemic heart disease, infective endocarditis. And one more cause of mitral regurgitation. Absolutely. Mitral valve prolapse. Spot on. Well done. And clinical features, which is kind of what we spoke about, they can present with shortness of breath, exertion particularly, palpitations, and signs of failure. So they can have swelling, ankle edema, maybe a bit of orthopnea, PAD, but commonly they present with exertion breathlessness. Volume overloaded, so the apex can be displaced, and we mentioned about the third heart sound which can happen in conditions like mitral regurgitation, common cause for third heart sound. Okay, a few important points there about the mitral regurgitation as well. Systolic murmur really is in a loud respiration. You can get like a heat at the apex if you put your hand there. Okay. Right. 74-year-old lady presents to MAU with a touring history of orthopnea, ankle swelling, abdominal distension. Past medical history is ischemic heart disease and AF. Just before we move on to the examination, just from the history, what are your thoughts? So this lady has got orthopnea, ankle swelling, and abdominal distension. Why mitral stenosis? Okay, yeah. Yeah. Good. So he's got a bit of signs of failure. But what's different about this failure? What extra information have we given you in this history? Ankle swelling. Yeah, okay. Anything extra? Abdominal distension. What do I mean by that? Sorry? Ascites. So, any of you buddy gastroenterologists? Yeah, probably not, but tell me why this lady may have ascites. What's going on with the heart? Right side of heart failure. Okay? So think right side of heart failure if you see abdominal distension and obviously signs and symptoms of other signs and symptoms of heart failure. So we move on. JVP is very, very raised, really reaching the earlobes, pitting ankle and sacral edema. That's all kind of coinciding with the right side of heart failure. Diffuse crackle cells are both lungs, ascites as we mentioned, but there's no signs of chronic liver disease. Right side of heart failure, what valve am I talking about? Tricuspid is probably the only one left to do, isn't it? So tricuspid regurgitation is what I'm talking about here, and then that can cause right-sided heart failure. What's the murmur in tricuspid regurgitation? Pansystolic murmur. Good. Where is it heard loudest? Sorry? Tricuspid region, which is the left sternal border. Right. So this is a pansystolic murmur. Okay, heard loudest in the tricuspid region. You talked about mitral regurgitation being pansystolic murmur, which in most cases can be heard throughout the precordium. How do you differentiate the two?
Inspiration,
Okay, that's the key here, right? Tricuspid regurgitation will become louder in inspiration, right? Whereas MR doesn't really change in inspiration, and it probably changes a little bit in expiration. Okay, so pansystolic murmur, left sternal edge. Important points: it can cause right ventricular failure. You can have ascites. Talk about the pansystolic murmur, which is loudest in inspiration. That's called Hartler's sign. If anybody wants to know, JVP very very high. You can get a left pansystolic edema. I think the key thing is right heart failure. Maybe ascites because of the right heart failure. And this. How you differentiate from mitral regurgitation. Okay. So if you see the MP's right heart failure and asking you about murmur, think tricuspid regurgitation. Mitral regurgitation more left side of the heart failure. Okay. 22-year-old male presents for a routine physical exam. He was referred to cardiology because of a murmur and wanted clearance to play sports. Family history of sudden cardiac death. What are you thinking? Long QT syndrome. Wow, definitely by his diagnosis. Yeah, okay, long QT syndrome. He was referred because of a man. Don't get that long QT syndromes. Could do, but yeah. What's more common for you guys? Sorry? Okay. Hypertrophic obstructive cardiomyopathy, okay, what we're trying to talk about here. What's the murmur? Ejection systolic murmur. Good, okay, right. Here we go, here's the next question then for you. Ejection systolic murmur in Hocum. Aortic stenosis is an ejection systolic murmur. How are you going to tell them apart? Help him out, he says. Anybody, it's fine, anybody.
Radiating to the carotid?
Yeah, very good. Can radiate to the carotids in aortic stenosis. Okay, I'll give you that. Anything else? How do you tell that this is Hocum and not aortic stenosis? What could you do during an examination? Good, who said that, sorry? Oh, yeah. Valsalva maneuver. What else could you do? One more maneuver you could do.
Is it squatting?
Yeah. Okay, good. We'll talk about how the murmur changes in each of those two. So those are the key things to differentiate between an ejection systolic murmur and differentiate between aortic stenosis and Hocum. So in Hocum, you get a very good double label impulse. You feel very, very good. As I said, it's a harsh ejection systolic murmur throughout the precordium, probably louder in left sternal border. You can get a pansystolic murmur, which is consistent with MR as well, and it's the maneuvers which really have specific effects on this murmur. Valsalva will increase the murmur, squatting will decrease the murmur. Okay, of so a key thing. How do you do about Valsalva maneuver? Yeah, okay, let's blow into a syringe. So basically, the little end, and try and blow out the syringe, and that's a good going Valsalva maneuver. Maybe another cardiac condition where you can do a Valsalva maneuver. SVT, yeah, SVT is another common thing that we do. Valsalva maneuver. So just remember that for your EMQs, the specific maneuvers to differentiate between aortic stenosis, and OCA. What is the ECG showing? Anyone? No? Anybody have any, just talk, common, what strikes you about that ECG? You did the other one as well, didn't you? Yeah, left ventricular hypertrophy. Look at these things, look at this, as I was saying, if we count all of these squares and these squares, and if we count this 1, 2, 3, 4, 5, 6, 7, 8, 9, let me have the H.
So you add them up,
Add them up.
B2 and B5.
Yeah, well, basically you count the one that's most downward and the most upward. So yeah, roughly, yeah. And they're usually 7, roughly if they equal to 7-ish, then that's LVH. But that's LVH associated with OCA. Okay, which is also associated with aortic stenosis. In terms of signs and symptoms associated with OCA. Anyone? Apart from death, sudden cardiac death. Any signs and symptoms of OCA? What do you think they present with if they've got a problem with the blood flowing out of the left ventricle? Kind of obvious symptoms would they present with? Sorry? Shortness of breath? Yeah, absolutely. Shortness of breath. Anything else? Syncope? Yeah. Anything else? Angina, absolutely. Chest pain, shortness of breath, syncope, palpitations, blood struggling to flow out of the left ventricle. Typical symptoms of OCA. Chest pain, shortness of breath, syncope, palpitations. Okay? What's the common arrhythmias associated with OCA? Why do they die? VF, common ventricular fibrillation. What can happen before VF?
BP.
Ventricular tachycardia, another common one that you can get with OCA. Okay, you can get a lot of ventricular exercises as well. And yeah, ventricular tachycardia and VF are the most likely causes, most likely arrhythmias which are associated with OCA. What's a Graham? That's OCA. Any questions? No? Let's see, what's the Graham-Steele murmur?
Pulmonary hypertension.
Who said that? Okay, pulmonary hypertension. Tell me a little bit more. Okay. So basically, Graham-Steele murmur is effectively is associated with pulmonary regurgitation because of pulmonary hypertension. Okay. So it's an early diastolic murmur at the left second intercostal space. So effectively, it's a pulmonary regurgitation murmur at the pulmonary area, and the pulmonary regurgitation is caused by pulmonary hypertension. What do we mean by pulmonary hypertension? Break it down. What does it mean? High blood pressure in the pulmonary system. Right? Pressure is increased in the pulmonary system. What can cause pulmonary hypertension in the lungs?
COPD.
Yes. Common chronic condition, COPD. It's a good one. Okay. How do you so? As I said, I like asking these questions. It's the same, similar manner to aortic regurgitation. How do you differentiate with? How do you differentiate the two? Inspiration, expression, isn't it? We talked about that. Pulmonary regurgitation with inspiration, whereas in aortic regurgitation, it's expiration. Remember, you said them up. Blow it out. That's a cool puppet. Who is it? know, pulmonary regurgitation kind of increases with inspiration, whereas in aortic regurgitation it increases in expiration. That's the maneuver that we were doing earlier during your examination. And pulmonary hypertension, which is basically because of COPD, which causes pulmonary, which is heart problems as a result of lung problems. That's what we mean by pulmonary. We get a heart condition as a result of a lung condition. Okay. Right. And of course you can get pulmonary hypertension from hyperstenosis as well. Cool. Probably saw that one, didn't you? Atrial ductus arteriosus. First of all, what is it? Yeah, that goes in from the pulmonary system to the aortic system. What's the murmur? Say that again?
All the way across from hand to murmur?
Yeah, like a machinery line murmur. Fantastic. What's ASD? Come on, guys, what's an ASD? I know what it stands for. What does it mean? What is an ASD? What is that? Anybody? What's an ASD? What do you mean by what's happening to the blood flow? Say that again? Yeah, so it's a left to right jump from basically blood is flowing from the left atrium to the right atrium. Good. What's the murmur? What's the murmur in ASD? Ejection systolic murmur. Indeed. Indeed, it's an ejection systolic murmur. What's another common thing that happens in ASD with the heart sounds? So again, somebody said something. Who's talking, sorry? Yeah. Yeah. So the second heart sound split. Remember at the start we mentioned that the second heart sound can split during inspiration. In ASD, it's what we call fixed splitting of the heart sound. So inspiration makes no difference whatsoever. Okay. Basically, so it's an ejection systolic murmur and fixed splitting of the second heart sound. So whether they breathe in or out, it doesn't make a difference to the heart sound, it's still split. Firstly, because of the left to right shunt, and it takes a bit of time for the right side valve to close compared to the left. VSD? What's a VSD? Anybody? Where's the blood flowing from and to? Left ventricle into the right ventricle, and what's the murmur? Anybody? And systolic murmur, okay, in a VSD. And finally, in a mitral valve prolapse, you get a mid-systolic click, which is very different from the opening snap, which remember, the opening snap happens in diastole because of that valve, the thickened mitral valve opening during diastole. This is a mid-systolic click, so it's happening between the first and second heart sound. So the little click that you hear in mitral valve prolapse. Yeah?
Sorry, this is done, but what's the difference between the opening snap and the first heart snap, the loud first heart snap that you were explaining?
It's effectively similar. It's very, very similar. So the loud first heart sound, you can effectively put your stethoscope down, and it's very loud compared to the second heart sound. And the opening snap is effectively it's like describing the loud first heart sound. So you're effectively hearing it snap. So they're effectively the same thing, is what we're saying. And there isn't really a huge difference. Okay. Right. Okay, have you guys been listening? Should we do some questions? And then I can go back. Yeah? Okay. Yeah, sorry.
Sorry, just a question on the atrial septum
Yeah?
You mentioned that injection systolic phenomena. Why is it systolic? Because after emptying blood during systolic,
Because it's a constant shunt. So whether it's usually in systole, so as the heart is pumping from the left atrium to the left ventricle, the blood comes from the left atrium to the left ventricle during systole. So as it pumps, blood is shunting to the left, right atrium during systole. That makes sense?
blood is still going from atrium to vertical during systole.
Yeah. It's going from the ASD's left atrium to a right atrium shunt. And when the blood is pumped during systole, through the mitral valve, blood gets pumped through that lever. Blood is shunted from the left to right. That's why you get systolic moment, it's more obvious. So the pump is okay? Cool. Right, question number 1. Shall we do question 1? Should we do this side? Yeah? Alright, so who's gonna give this one a go? You've got a 60-year-old man, 2-month history of progressive dyspnea and chest pain. You get an ejection systolic murmur, second right intercostal space, radius of the carotids. What's your diagnosis? Is everybody happy with that? Yeah? Cool. Let's do the middle section for question number 2. Routine physical examination, 30-year-old man. You hear injection systolic murmur, left lower sternal border, doesn't radiate to the carotids, becomes loud when the patient asks to perform last part of the maneuver. What we describe it. Sorry? Oakham, yeah, absolutely. Very different from. You guys hopefully would have picked up some stuff from the earlier talk, so that's describing Oakham. Ejection systolic murmur, louder when they are performed the last half of the maneuver, and it doesn't go to the carotids. Here we go, right this side of the lecture theatre. 25-year-old pregnant woman is referred to because of a heart murmur during the second trimester of pregnancy. Her first pregnancy, no history of cardiac disease, and it wasn't noted during the previous exams. She's asymptomatic. What murmur am I describing? Sorry? Yeah, simple innocent murmur, as we mentioned. It's always a systolic murmur, and it is indeed a systolic murmur. And you can, from the examination, there isn't anything really to find. But a third heart sound, as I said, very common in pregnant women, and it's a systolic murmur, and it's a mid-systolic murmur, which is a very common for innocent murmurs. Okay? Let's go back to this side. 26-year-old man seeks your advice because he was diagnosed as having a heart murmur as a baby. At this time, his parents were told he would outgrow this murmur. He participates actively in sports without any cardiac symptoms. We do an examination, and first heart time is normal, second heart time is physiologically split, loud pan-systolic murmur, left sternal border, going to the right side, and there's no third heart sound or fourth heart sound. Anybody? He's had it as a little baby. He's got a physiological splitting of the pan-systolic murmur. What's that? Is it an atrial septal defect? What's that? What is the other one? It's a pan-systolic, so it's a VSD. Okay, injection systolic is an ASD. In VSD, you can get physiological splitting of the second heart sound as well. So that's why you differentiate ejection and pan-systolic, the two VSDs. Middle part of the lecture theatre, 42-year-old woman comes to a clinic for evaluation of angina and dyspnea on exertion for 6 months. She has no cardiac history other than a long-standing murmur. Any thoughts from the middle section? You do an examination, normal first and second heart sound, got a fourth heart sound. It's a late ejection systolic murmur, which increases with Valsalva, and when she rises from squatting to standing. what we described. Anybody? What's the history telling you? No. Why not? Tell me why it's okay. Yeah. Good. Let's do an EMQ.
I thought squatting decreased it.
Did I take the other way around? So yeah, sorry, my mistake. I just got to joke about this. So what the other one is the message. Sorry, my mistake. Right, EMQs. Finally, question number 1. Young female with a mid-systolic click and a late systolic member best heard at the apex. Oh, you have a question, sorry?
So you know for squatting, would it get quiet as you squat?
Pretty much, yeah.
So as you get back up, would it get
Louder.
So it was right.
Yes. I'm getting confused now. I'm getting very confused.
You said as she gets up from squatting, it gets louder.
You were the first one to say
Did I? When she rises from squatting to standing. Sorry, yeah. Yeah, so it's not. Is it? Am I? Is that? Yeah? Yeah. Yeah. Sorry. My mistake. I wrote the question last night. Okay, so what's number 1? A young female with a mid-systolic click and a late systolic member best heard at the apex. What's that? Mitral valve prolapse is a mid-systolic click, yeah? Young boy with fixed splitting of the second heart sign and ejection systolic murmur. Anybody? ASD, okay. Remember, it's fixed splitting and injection systolic murmur. Elderly lady with a loud first down sound opening snap, read diastolic murmur. Mitral stenosis. A middle-aged man who's learned to have ankylosing spondylitis. Early diastolic murmur, left sternal ledge. Aortic regurg. Becomes easy now when you know, isn't it? And an elderly lady with a soft first heart sound and a blowing pansystolic murmur, mitral radial go to the axilla. Mitral regurg. Okay. You guys are going to do some final bit of work, and then we're all going to go home. Tell me a few things you learned about aortic stenosis.
Ejection systolic.
Ejection systolic murmur. Great. Anything else? Radiated the carotids. Fantastic. Anything else? Narrow pulse pressure. Fantastic. Carry on.
Syncope.
Tell me the triad of symptoms, not just syncope.
Chest pain.
And
Syncope.
syncope, chest pain, and shortness of breath. Good. Fantastic. Good. Okay. So all the stuff that you guys mentioned. Okay. Mitral stenosis. Tell me a few things you've learned. We're never going to leave at this rate. Yeah, loud first loud sound. Carry on.
Mid-diastolic.
Mid-diastolic murmur. Carry on.
Doesn't radiate.
Yeah, it doesn't radiate. Okay.
Snap.
Opening snap.
AF.
AF.
Pulmonary edema.
Pulmonary edema. Good. Good. Finally, you get somewhere. Sorry. Tapping at next speed. Good.
Rheumatic fever.
Rheumatic fever. Fantastic. One more. Nalar flush. Fantastic, guys. Well done. Okay. Loud first start sound, opening snap, apex, and all the other stuff that you guys mentioned. Aortic regurgitation. Come on, tell me a few things. Collapsing pulse. Good. How do you do a collapsing pulse? Yeah, so you hold it up, yeah, fine. Everybody knows, fine. Carry on, anything else? Sorry? The Marshall sign, fantastic, well done, what's that?
It's when you get noticed on that.
Good. Carry on.
Early diastolic.
Early diastolic murmur, heard where?
Point.
Okay, well done, actually. Carry on, Herb's point, carry on. Quinkies, which is? Capillary pulsations. Capillary pulsations, Quinkies pulse. Carry on.
Connective tissue disorders.
Connective tissue disorders is associated with. Fantastic. Anything else? Displaced apex being because of volume overload. Carry on.
Asymptomatic.
Yeah, asymptomatic in most cases. One more thing. Corrigan sign. Well done. And one more sign. Corrigan sign is what? Visible corrosive pulsation. And one more sign. Yeah, it's like that band at the femorals. Well done. Well done. Okay. And mitral regurgitation. What have you learned? I don't think this time of the finish. That's it. Mitral regurgitation. What have you guys said? Fastest going in the third loudest. Fantastic. And anything else? Yeah, good. Well done. Showed us a breath palpitations on evaluation. No problem. Well done. Good. Anything else? Yes, pneumatic fever and carditis. Good. And one more common cause of mitral regurgitation. MI and mitral valve prolapse. Very good. Fantastic. And finally, open. Ejection systolic murmur. Heard loudest? What's that? Yes, tricuspid area. That's the order. Carry on.
Doesn't really.
Doesn't. Yeah. Okay. Anything else? Yeah. What else? Symptoms? Yeah. Yeah.
Family history similar.
Yeah. One of the common arrhythmias? Yeah, okay, good. Right. Does everybody want to go home or do you want to listen to some notes? You're not tired? Jeez. Okay. Right, very quickly. Any questions so far? No? Okay. What's this? I hope it works. Anybody? Is it? It's normal, yeah. It's normal. Alright, next one. Probably not very clear. Ejection systolic, so what probably most likely aortic stenosis, okay. Anybody? What was that one? Probably a third heart sound in there, but there's a murmur as well. It's difficult to hear, it's systolic murmur. Probably mitral regurg. What's this? Third heart sound. It's like somebody racing, isn't it? That's definitely a third Okay, what's this? Not very clear. Can't really hear that one actually. Let's try this one. No? It's normal. Come on, guys. Everything doesn't have to be abnormal. Jeez. Okay, what's this? Anything? Right? Is it different from this one? It's not very clear, but give it a go. Any other guesses? Not able to guess. Yes, anti-stolic murmur, probably with mandatory agitation. And finally,
What's the one before?
it's the same. It's meant to be the same, but it still wasn't very clear. What's this one? Oh. What's that? AF? What's that really? Yeah. Aortic stenosis. Yeah, good. What else could it be? An ejection systolic murmur. Okay. One more, it could be? Yeah, one more. Pulmonary stenosis. So 4 things for ejection systolic murmur. Alright guys, any questions? Yes? Yes, I can email it to Steph. Yeah? And she can forward it to. I don't know if you give your email address, I guess. Or you can give your email address to me. Yeah, just pop it on a piece of paper to me. I'm happy to forward it to you. Any questions? You guys, good luck in your exams. I'm sure you will do very well, and I might see you around. Alright, no worries.
If you guys can all fill out the feedback forms for us, that would be really wonderful. And then in 1 week we have ECGs for OSCEs. So we'll have a lecturer that will go through any ECG that might come up. And then we'll have opportunities for you guys to present to part numbers in small groups. So that's next week here at 3 p.m.
Anyone who wants the slides, if you're not already on the whole slides, I'm going to just come to the front and we'll take your email address and we can send it to you.
Don't feel like you have to.